Hello guys, I hope you guys are doing great. This is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, quickly, I just want to express my gratitude to Dr. Nolwazi Mkachwa. I want to say thank you so much, Doc, for agreeing to do the video and sharing with us those tips. And I'm sure you have seen people loved it. People loved you, and yes, I'm getting a lot of WhatsApp messages, even Facebook messages. People like they really find your tips very helpful, in that they do believe that they are gonna become better students when it comes to clinical rotation. So guys, so thank you so much, Doc, for that. Thank you so much for Doc, for that. I mean, guys, Nurazi is a very nice person. She's a very nice person. She's a very humble, and she's very hardworking, and also she's like brilliant, guys. Like she's brilliant. She's brilliant. You know, she's one of the most brilliant students that I've had an opportunity to be in class with in my entire life. That's how brilliant she is. Guys, she's brilliant. She's brilliant. She's brilliant. So those tips are from someone who's brilliant. Those tips are from someone who got a cum laude, guys. So don't take them lightly. Thank you so much for showing her love. You've showed her a lot of love, and she loves you back. And she even said to me that there are things that she thinks that she would want to jot down again and then come back with part two when she finds time and all of that. And I said she's welcome. So we're gonna wait on her and wait for that day when she sends the video. So guys, yeah, thank you so much. Thank you so much for showing her love. Yeah, so guys, just before I start today's topic, I just want to say to you, you know, medical school has driven a lot of people to the grave. People have committed suicide because of the pressure, because of the harshness, because of all these things that are happening in medical school. And I'm not only talking about, I'm talking about in the whole wide world. In South Africa, it happens. It happens a lot. The pressure and all of that. In medical school, there's like a lot of pressure. There's like a lot of pressure. And remember, we go to medical school knowing very well that we need to come back, get a job, and take our roles as breadwinners. So it get to a point where you cannot afford to fail, and that pressure, and also you see academically, you can see that you're not doing well, and your family is also on your back, and all of that. It just becomes too much. So many students are on antidepressants. Many have committed suicide. Even registrars, they still commit suicide, and all of that, and all of that. So guys, so this platform is to help students, guys. This platform is to help students to I mean, obviously they are, like I always say that when you get admitted to med school, you need to keep all the support that you have, support systems that you have. You need to keep them, spiritual, financial, all those. We need to keep them, and the bit I can do is to support you guys academically, because I've walked through that path and I know how it is. I remember when we started SIC as the class of 2019 with Abonolwas and all of that. Yes, we were anxious. We didn't know what to expect, and we were told that SIC is grilling, SIC is tiring, and it is tiring. It is grilling, yes. It is exhausting, and that's why you need all the help that you can get, so that you don't have to worry other things. So that you don't have to worry about, just to take the pressure a bit off your shoulders. So that's what this is all about. It's about helping you guys to bridge that gap between basic sciences and clinical medicine. That's why the channel is called Clinical Medicine with Dr. T. So it's to help. I know clinical reasoning is a skill. It doesn't just come, and doesn't come from a book. It's a skill that you learn as you go to the hospital every day and see how things are done. Then you develop your clinical reasoning. It grows. Like I said, the more you attend clinical rotations, the more you will better your clinical skills, your judgment, your thinking. Because finally it's all about that. It's about, they want to test you. Can you think clinically? Can you judge? Can you make clinical decisions? Okay, that's what they want to do. They don't care about your, they don't really care about how good you know your physiology. Yes, it's gonna help you to make a decision, but right now, I mean, a patient doesn't care how good your physiology is. What they want is, by the time they leave you, they must be feeling better. So we are bridging a gap between basic sciences and clinical medicine, because it's a very big gap. It's a very big gap. So guys, yeah. So what I want us to talk about today is, so I wish, guys, we can subscribe as much as possible, share as much as possible, so that we can reach even the students that we think that we cannot reach, like all universities in South Africa, all the 10 universities in South Africa, and even go abroad. That's the plan, guys. That's the plan. So keep subscribing, keep liking, keep commenting. Let us grow together. Thank you so much. You might find that some of you, in the next few years to come, I'm gonna invite you to the channel and be like, okay, can you come and tell us how did the channel help you? Maybe by that time you'll be at an intern somewhere or an MO somewhere. So guys, let's do this. We can do it. Let's do it. Yeah. So guys, what I want to talk about today is, let's talk about mood disorders. So the DSM-5 now has sort of like separated depressive mood disorders from bipolar and related disorders. They are no longer together as mood disorders, but I'm gonna bring them together for the sake of making it easy to understand. So I'm gonna call these mood disorders because they are mood disorders, right? They are not psychotic disorders. They are not anxiety disorders. They are not your sleep-wake disorders. They're not your eating disorders. They are mood disorders, right? Okay. So now, I'm gonna draw a line like this. And I'll draw a line like this. So guys, this is an overview. This is just an overview. It's an introduction to mood disorders. Right here and right here, we've got the two ends. Here we've got low mood. We have low mood here. And here we have elevated mood. Right? And I'm going to put here, this is not euthymia. This is not a normal mood, this part, but I'm going to explain it later. So someone who's got a low mood, it's a depressed mood. It's a depressed mood. So we're going to do depressive disorders here, basically. And then here we're going to do disorders that have got an elevated mood, such as mania, hypomania, right? You might say that this is too much happiness. It's too much happiness that is accompanied by irritability, that is accompanied by someone who doesn't want to sleep, reduced need for sleep, goal-oriented movements, talkative, pressured speech. That's the kind of thinking mood there. And then here you've got this person who's not, doesn't want to talk. So this is the opposite. This person talks too much, pressured speech. This one has got alopecia, he doesn't want to speak. This one, they are sort of like they've got psychomotor retardation, unlike this one who's moving up and down, cleaning, washing, refusing to sleep. This one wants to sleep. This one wants to, they're refusing to eat. They want to just sit. They want to isolate themselves. They don't want to talk. They're just feeling sad. They're just feeling unwell. They are feeling hopeless. They are feeling empty. Right? And now, these are the two extremes. Now you've got people that are here. These are disorders, guys. There's nothing normal here. So my mood is not gonna be here. Your mood is not gonna be here. I'm talking about disorders here. And then now you've got people. This is one pole. This is another pole. Now you've got people who have got features from both of these. Those are your bipolar. Bipolar mood disorders, right? Those are your bipolar mood disorders. Bipolar mood disorders. So what is common about so this is let me call it an umbrella, depressive mood disorders. It means that they are disorders or conditions that are under this umbrella, but these conditions, they share similar symptoms. So there's sadness. They feel sad. These ones, they feel sad. They feel empty. They feel hopeless. They feel, so basically there's hopelessness, there's sadness, they feel empty, and the likes, other symptoms are related to that. So now the conditions that you find here, the most common one, or the most the most common one would be your major depressive disorder, MDD. Major depressive disorder. We are going to talk about this one by one, but now I just want us to mention them. So major depressive disorder, and then there's what they call disruptive mood dysregulation disorder. So disruptive mood dysregulation disorder. Dysregulation disorder. We are going to talk about these guys, right? And then there's also persistent depressive disorder. Persistent, we are going to talk about them, how they differ. But these symptoms are in all of them. So, are in all of them. Persistent depressive disorder. Persistent depressive disorder. And then we also have premenstrual dysphoric disorder. Premenstrual dysphoric disorder. And then now we can have depressive disorder, secondary to substance or some kind of medication. Or we can have depressive disorder, secondary to another medical condition. We can also have specified or unspecified. So we are going to talk a lot about MDD, the most common, like I said, amongst these disorders is the most common. So these patients, they share these symptoms, and the difference will be these conditions, they differ. One, they differ in terms of the duration. They differ in terms of their timing. When do they actually occur? They differ in terms of their presumed etiology. Presumed etiology. So obviously, one of the things that accompany all these would be your somatic and your cognitive changes. Somatic and cognitive changes. So those are depressive disorders, guys. I always say that when you study psychiatry, it's important to know, to have a general idea of what's happening, other than going straight into MDD and read and know MDD in and out, but you don't appreciate, you don't understand where does MDD fit. And remember, the easiest way of studying is to study by association. So if you know that MDD is under depressive disorders, and if it's not MDD, it could be this, it becomes easy to get a differential. It becomes easy to also to answer questions as well. So let's move on to, so this is an overview, guys. Like I said, it's an overview. So now, when you talk about, so what we're going to talk about when we are going to talk about mania, how to differentiate mania from hypomania. So there are differences in terms of the duration and also, but in general, hypomania is a milder form of mania. Yes, there's also a duration thing, like hypomania is about four days, though mania is more than 4 days. But the symptoms in hypomania are less severe compared to those that are in mania. Okay. Now let's come to this part. So here, there are a couple of conditions that you find here. Let's talk about bipolar type 1 and type 2. What's the difference now? So with bipolar type 1, you have a manic episode or episode of mania plus minus a major depressive episode. So you don't have to have a major depressive episode in order to be diagnosed as bipolar type 1. So the most important thing there that needs to be there is mania. So the major depressive episode, it's a plus or minus. Or you can have a mixed episode. So you can have a mixed episode, or you can have hypomania. But the hypomania that you get, there must be a previous history of mania. It's very important. It's very, very, very important. So what I'm saying is, for bipolar type 1, what is needed there, it's a manic episode plus minus a major depressive disorder. That's like number one. You can have that, or you can have a mixed episode, meaning major depressive episode or or mania. The third one, you can have hypomania. The patient can present with hypomania, but with a previous history of mania. That's your type 1. And then now, for type 2, you need hypomania plus major depressive episode. That's type 2. And then now, there is under the bipolar mood disorders, there's what they call cyclothymia. Cyclothymia. So cyclothymia or cyclothymic disorder, it's a patient who comes in with so this patient has got features of hypomania, but they have features of numerous, like many episodes of features of hypomania or mania, but they don't exactly meet the criteria for mania. They don't exactly meet, so they've got like hypomania-like symptoms, or they've got mania-like symptoms, but they don't exactly fit into mania or hypomania. And this should happen for at least 2 years. So which means now you cannot say they are manic or they are hypomanic, because they've got features that are similar to these. It's either similar to this or similar to this, but they don't fit. They don't really fit into any of these episodes or episodes. So now you are sort of like in between. So those ones are diagnosed. So you need 2 years for adults and 1 year for adolescents. So these are your. And now you can also have bipolar mood disorder secondary to a substance or some kind of medication, or you can have it due to another medical condition, right? I'm not sure if I'm leaving anything out, but like I said, we are going to talk about. So now we're going to tackle depressive disorders. We're going to do them one by one, and especially the most important ones like MDD. You cannot not know MDD. Okay, so this is our broad overview. Okay guys, let's meet in another video. Thank you.